Good evening. Great to have you folks here. What a glorious day it was, and so great to have you here. It really is with pleasure that I welcome you to this first of our two-part series on the future of American healthcare. We are really delighted at Concordia to bring this conversation that has dominated the national stage to a forum here at Concordia. As you all know, President Obama signed the Affordable Care Act in 2010, putting into place comprehensive health insurance reforms that began to roll out this past fall. To some, this has been the most significant legislative accomplishment since FDR, and to others, Obamacare has become a new curse word. Our goal in this two-part series really is to bring some clarity to these divergent perspectives and perhaps help us navigate the impact of this legislation on both our personal and our collective lives. Tonight, we are fortunate to have here with us Dr. Ted Marmer to help us to get this conversation started. Professor Emeritus of Public Policy and Management and Professor Emeritus of Political Science at Yale University, Dr. Marmer earned his BA in American History from Harvard and studied philosophy of language at Oxford before returning to Harvard for his PhD in political science and public policy. He began his public career as a special assistant to Wilbur Cohn, Secretary of HEW, in the mid-60s. He was a senior social policy advisor to Walter Mondale in his presidential campaign of 1984 and worked briefly with the Clinton healthcare team before joining the Yale faculty in 1979, where he taught till 2009. A world-renowned scholar, an award-winning author, he has published over 100 articles in a wide range of scholarly journals. He contributes frequently to op-ed pages in both US and Canadian newspapers and commentary on national television and radio. If you happen to watch his tie later on, ask him about his tie with the Canadian and American flags on them. He has written 11 books, including his most recent, Social Insurance, America's Neglected Heritage and Contested Future. Reviewers proclaim it balanced, compact, and informative, written for the general reader as well as the experienced analyst, and maybe one of the best volumes of introduction to American welfare state ever written. We are most fortunate to have him here with us this evening, and please help me welcome him to our meeting. Thank you so much.
Well, when you're introduced that way, what occurs to me is the thought that my mother would be very pleased if she were here. Thank you very much, President George, for that. And I have to say, I am just delighted to be with you tonight. That's not true of every speech I give, but it seems one of the first days of spring today, and how could you avoid being in a good mood with that coming? That's one reason. A second reason is that the topic that President George laid out turns out to be the topic I actually want to talk about. If you looked at the title of my talk, The Future of American Medical Care, you'd have no idea what I'm going to talk about. Notice about any title called The Future of, the major feature of such a title is that nobody can be shown to be wrong. All right? The future, we don't know. So I didn't want to talk a lot about the future. I wanted to talk about really how to understand this episode in American public life called healthcare reform, initially derisory use of the word Obamacare, and now more descriptively, the healthcare reform of 2010. But before I say a word about that, whenever we're talking about healthcare or health, it's important, I think, to loosen up a little bit. And the following story, actually two stories occur to me. The one that I like the most is the problem of any speaker trying to reach an audience like you. And it's a true story. And the story is of the election in 1960, the contest between Richard Nixon and John F. Kennedy. And this story was told to me about 20 years ago, and allegedly is true. And it captures the problem of a speaker being able to reach an audience. What happened, apparently, is that Adlai Stevenson, who contended in both 52 and 56, lost to Kennedy in the primaries, was quite angry at losing to this upstart from Boston. And the Kennedy team was desperate to get this great orator to speak on behalf of the candidate. So finally, they encouraged him to come to Philadelphia, and so he came, gave a speech, and at the end of the speech, a woman of mature years came up to him and said, rather worshipfully, "Governor Stevenson, that was the most wonderful, superfluous speech I've ever heard." Stevenson thought irony was the right response, so he said to the lady, "My dear, given your enthusiasm for my speech, perhaps I should publish it posthumously." To which the poor lady said, without thinking, "Oh, wonderful, the sooner the better." So that's one speech that captures it, but there's another one about health that's even more important to get through in order to get us into the talk about Obama's reform. And this is another story that was told to me when I was a young academic at the University of Chicago in the mid-1970s. And it has to do with a Swedish doctor, a GP by the name of Svensson. Dr. Svensson comes in on Monday morning to his office, and his nurse and office manager reports that there's an agitated 94-year-old gentleman in his office insisting that he see Dr. Svensson immediately. Dr. Svensson says, "All right," goes into the office and said, "Sir, could I help you?" And the 94-year-old gentleman grabs a magazine, which in Swedish is Prevention, and says, "Is it true what this article on prevention says?" Svensson says, "I don't know. What does it say?" "Well, it says the following. It says, if I become a vegetarian, at least most of the time, if I give up at least half the consumption of red meat that I've had, if I forego sexual life entirely, if I no longer drink, and I give up cigars and my pipe, and I walk 3 miles a day, is it true that I will live 3.4 years longer?" Svensson rubbed his chin and he says, "I don't know about the science of it, but it will seem a lot longer." So that's background. Foreground, how to talk about this topic called health reform in the United States, 2008 to 2014. And what I want to do about that is step back for a moment and acknowledge that for many of you, and for every audience that I've spoken to, this legislation, the question about what needs and is being reformed in American medical care, is a matter of deep interest and lots of strong feelings and strong values, both positive and negative. And so the way I want to begin is to turn this around from a conventional description, evaluation, judgment call, and instead say, listen to me pose this as a puzzle, first of all, as a puzzle, to be understood before we do any evaluation at all. And the way I would put the puzzle to you that I think is accurate, that is, it's puzzling, is as follows. Ask yourself the question, why would a president, a Democrat, elected in 2008 by a reasonable margin, facing a Democratic House of Representatives and a Democratic Senate with 60 Democrats to deal with the question of a filibuster, Why would a Democratic president in those circumstances strategically choose to follow a course of reform that had been outlined by Republican economists at the Heritage Foundation in the 1980s? Now, just give me credit for that being accurate. If I'm accurate, how could that be so? Why would that be so? It is so. It was designed by Stuart Butler, one of those economists at the Heritage Foundation, whom I debated a lot in the 1980s. So that's the puzzle. Not how do you evaluate it first, how do you understand it? Why would that be so? And I'm going to now proceed to try to give you an answer to that question before I get to the question of where we are now and where are we likely to be. Fair enough? Are you with me for that? Okay. I think the individual account of why Barack Obama decided to select that strategy has very much to do with the kind of accident of the U.S. Senate in the early 2000s. Barack Obama was a pretty inexperienced political figure, had only been one term elected. He'd been a state senator in Illinois, not doing very much actually with medical care. And he came under the sway of Tom Daschle, the former Senate Majority Leader, the South Dakota Democrat, had been in for a long time in the House and a long time in the Senate, who actually was defeated in 2004. And since I had worked with Daschle in the early 1990s, I knew something about his views, and I know two things about this. One, that he was very central in persuading Obama to run for the presidency in the first place. That's one. And two, he expressed to Obama a view of what had happened in the Clinton years that was hugely important to him. And what that was the bitter disappointment in 1993-94 that the Clinton reform, which was preceded by all this enthusiasm, 9 months of gestation, 500 people deciding what it was that was going to be in the managed competition within a budget, which was the slogan for this. And if you recall now for a moment, some of you will recall actually, but some of you will also recall from historical commentary, the Clinton proposal took 9 months from January to September, was introduced, a huge fanfare, and a year later it died of political lack of oxygen without ever having a vote. And Daschle's response to that was, good God, how had it been that we wasted this opportunity and didn't even have a vote? And so I believe it's very important to know what was said to the president-elect. And if you recall as well that Daschle was supposed to be Secretary of HHS and also was going to be healthcare czar, do you know enough about that historical stuff? Well, that's true. He was pushed out on a odd charge that he didn't get quite the right calculation about some auto gifts that he was given in the form of a driver. And just before Tim Geithner was going to be in trouble for failing to pay his taxes for a nanny, Daschle gave up and left. But leave that aside for the moment. Up to 2009, when the president was getting ready to get his cabinet, Daschle was the most important person in Washington, in my view, about what to do. All right, what did it mean for people like Daschle and Obama, and why would they have picked the plan that they did? I think two crucial parts of American public life are really important in understanding why they did what they did. But before that, let me just describe what they did. What they did was a 4-part reform that's really important to be clear about. One is that there was going to be an expansion of health insurance in the United States, not in one new program, not in an expansion of Medicare for all, but rather in 4 different parts. One, there was going to be an expansion of Medicaid, which has never been the front and center issue of reform for American Democrats. Always social insurance has, which is why I wrote the book I did. But Medicaid was going to be part of it, which has a more traditional connection to that part of American political thinking that believes the right role of government is not to provide a collective response for all of us facing a common risk, but only to act when it is that people fall into income poverty and need help. We can talk about that later, but the difference between means-tested or asset-tested programs and social insurance, the crucial difference is that in social insurance, where there's a common risk to income, whether it's disability, outliving your savings, injuries at work, whether it's being born into a poor family, or whether it's the sheer loss of wages from being sick, all of those are risks everybody ex ante is subject to. So social insurance is pooling around those risks and saying, if we all put into the pot, when and if we need it, we can take it out, but we don't have to prove anything about our poverty. That's going to be an important idea. And Medicare, for those of you who know about Medicare by experience or by family, you know that Part A of Medicare is an absolutely classic social insurance idea, right? There's an HI tax that comes out of wages on both the employer and the employee side, and when you're over 65 or have renal failure, you're eligible for Medicare no matter what your circumstances are. There's no tests of means, there's no tests of assets. Fair enough? Clear enough about that? All right. That's not what the president chose to do in 2008-9. What did he choose to do on the expansion of insurance side? I think one way to think about it is he was trying to move to universal health insurance by aggregating all the programs we now have. Not by having an expansion of one, but by adding to all of them. So there was going to be an expansion of Medicaid to involve people up to 138% of poverty. There was going to be a maintenance of Medicare for those over 65 and those who are disabled and renal failure. There was going to be a requirement that employers provide insurance or pay a penalty, and that employees and others without insurance would be required to pay into a pool for insurance, but with subsidies, right? You aggregate all that, that's everybody. If you require everybody to have insurance and all employers to either pay or pay into insurance, and if you have Medicare and Medicaid, that covers everybody. Now, what they didn't think about is how difficult it is to make all of that happen. But the idea was national health insurance by the aggregation of different programs. That was one. Two, there was a belief that because the diagnosis of American medical care had been that we were spending 18% of GDP at any one time in 2008-9, and we had 52 million Americans who were uninsured at any one time, and about 90 million Americans who were uninsured over a 2-year period at some time, we were spending a lot and not getting what we needed for it. And therefore, the cost control argument was we needed to control the costs of American medical care. We spend 40% more, for example, per capita than our neighbor to the north, Canada. And we are far and away the most expensive medical care system in the world. And so the idea was that cost control was a second theme of the reform, except that what was proposed for cost control by the Obama administration and would have been proposed by a Republican version 2 were 4 things, none of which are going to do anything about cost control. 1, by making prevention less expensive than care, the thought there would be more preventive services. And I dare say there will be more preventive services, but there's no reason to believe that more preventive services will mean less spent overall, for reasons that I will answer if you're skeptical about it. The second one is by the expansion of medical records. Electronic medical records was proposed as an avenue of cost control. No reason to believe that may improve the quality of American medical care, but it's not going to improve the costs of American medical care. The third is an expansion of IT itself. $20 billion was set aside. That IT, which may possibly avoid some errors, but the view that that will control the costs of medical care is based on no experience anywhere whatsoever. And the fourth was a belief in comparative effectiveness research. That is, if we knew what worked better than some other medical intervention, we would be in good shape. You've seen already that I'm pessimistic about the cost control side, and I'm willing to take on any argument the other side. I've spent 45 years worrying about this, but let me give you a hint as to why I feel so strongly about this. And let me do it in the form of principles that lead to an inference that you can't avoid. Principle number one, $1 of medical expenditure must equal $1 of someone's income. Will you reflect on that for a moment? If $1 is expended in medical care for whatever, it's going to be $1 of someone's income in the medical care world. Are you with me so far? Anyone want to attack that accounting identity? If you know what the words mean, it has to be true, right? So expenditure equals income of somebody. Now, if you go from that axiom to the next proposition, that entails that the expenditures for American medical care must equal the incomes of people in the medical care industry, right? If the first axiom is right, the second one must be right, correct? I want some agitation here. I need some eyes. I either say no or yes. Correct? All right? Look at what follows from that pair of axiomatic reasoning points. It means necessarily that the control of future costs of American medical care must be costly to somebody, or it's not true. There is no costless form of cost control. Right? That's the point. I mean, unfortunately, this is like a fact about the world, like the weather. It's not a matter of my preference for it or my hostility for it. It's indifferent to my views. But it's crucial for your understanding why those four things don't necessarily mean. If $1 of expenditure is avoided because of preventive action, and the doctor or the nurse or the hospital does something more, that's not the control of American costs. It's an improvement in the circumstances of the person whose preventive illness was prevented. Let me hold that for a thought, put it aside for the moment. Just say that's the proposition. Marmer says that cost control must be costly, and the Obama conception had nothing to do with making that plain. All right? Thirdly, and this is what's most interesting about this reform, it is a set of new rules for American health insurance. It's an effort to make private health insurance behave like social health insurance. No private health insurer would take in somebody over the age of 65 and say, let's see, your expected expenditures as a matter of the group over 65 are 10 times that of the age person 20. So I'm going to give you that insurance at a premium of 3 times the premium for the age of 20. Nobody would do that. If they did it, they should be fired, right? Because private health insurance has got to anticipate the aggregate costs of those people who pay the premiums, as this gentleman here is vividly expressing as he nods to my remarks. All right? So all of what you've been hearing, a compression of the ratio of acceptable premium differences between the young and the old, the barring of cutting off insurance with a lifetime limit, which is, again, trying to deal with the economic threat of illness in such a way that people could rely on it. But individual firms, again, understandably, are scared. If you knew that 5% of the population getting medical care account for 50% of the expenditure, you'd understand in a minimum why that's the case. Or if, for example, you were told that children up to the age 26 could be on their parents' insurance. Well, what insurance company would want a 24-year-old who had been hit by a car and was going to be one of the highest? The answer is they wouldn't want that. All of these rule changes are indirect ways to try to make American private insurance resemble the social insurance that Medicare illustrates. And then finally, the fourth part of this legislation is hundreds of special little programs that none of you know anything about. In order to get through the congressional process, it became like a Christmas tree where people put on one ornament or another, particularly as it got closer to passage. So what I want to say to you is this proposal, selected by the president in 2007 and 8, really, in the course, reflects an effort to combine many different things, none of which he effectively explained to the country at large. And so you've got a puzzle as to why that would be so. Why would this extraordinarily articulate president have not explained any of what I've explained to most of the country, leaving 60% of Americans, the polls say, unsure of whether they like this or don't like this? And I think the answer lies in the distinctive understanding of American political institutions and the fate of the Clinton failure in 2003, 2004. Think of it this way. American political institutions, both at the national level and across space, are structured in such a way to make it very hard to produce a coherent reform. They make it very easy to stop things. The veto points that are available are huge. The implication of that for this group of reformers and their interpretation of the Clinton phenomenon was that Clinton had erred by creating his own plan and sending it to the Congress instead of getting the Congress to participate in creating its plan where they had some ownership to it. So what did the Obama administration do? They gave it entirely to the 5 committees of the U.S. Congress on the aspiration, secondly, that they would get Republican support because they were doing what the Heritage Foundation said should be done in the 1980s. Did they get any Republican support? No, not one. Nothing. So the strategic assumption that you needed to take a set of expansionary moves in order to get the approval of at least centrist Republicans failed completely. And what were we left with? A bargained out result that you had to be a Washington enthusiast to figure out what was going on at any one time. Okay? So what do we have? We have a piece of legislation with thousands of pages in it, not understood by most people in the country, being talked about in ways that don't even engage one another. If you go to Florida today, if you listen to television and listen to the debate going on in Florida, the Florida House seat that's going on, the Republican is saying this is socialized medicine, even though it's Republican socialized medicine. And the Democrat is saying, well, we didn't get it right the first time, we better go back and fix it. In ways that nobody tells anybody else any compelling story. So, where does that leave me? It leaves me with the present. And this talk was advertised as the future of American medical care. As I said at the very beginning, the impressive thing about the future is you can't be sure about it. And if you think about where we are and think where we will be, I would say the way to think about that is to say it depends on the context of political mobilization and political domination of the Congress and the White House, and the economic circumstances looking forward. You put that together, you can have high growth or low growth. You can have Republican domination or you can have Democratic domination. You can actually also have split government, which is two other conditions. And under each of those cells, if you go through that process, vary the economic circumstances, vary the political domination, and include the possibility of split government, you will get 6 different projected outcomes. So the lesson, if I'm right today, I think I'm within my time, if I'm right today, my guidance to you about the future of American medical care is the astounding proposition that it depends. And I know how impressed you are by the fortitude of that prediction, but I mean it seriously. This was, let me add one more point to it and I'll stop and open it up for questions. Let me turn to at least 2 evaluations, one that I've heard a lot and one that I've proposed, of people who are saying positive things about the legislation, and then people saying skeptical things about the legislation. On the positive side, and by the way, this is completely separate from my own wishes. I haven't told you about my own wishes yet, but if you buy the book, you'll learn. That's hardly a celebration of the book, but nonetheless, there it is. Many people in debates have said to me, Ted, from the standpoint of the Democratic reformers, they got the best outcome they could possibly have gotten. There was no more room for something wider and broader to happen in 2009-10. And I agree with that. Anybody who thinks there was a policy majority for Medicare for all or some huge single plan, I think they can believe that it was desirable, but they can't believe that it was doable in that. But now, turn that around for a moment. The evidence that that was the most they could have done is that they did it. And then the question is, why did they do it? Did they do it? Because it was the most they could have done. And unfortunately, that gets you in a circular reasoning. That's just not true. I do agree that it was the most expansive thing to be done, but you have to ask yourself as an evaluator, what is a counterfactual? What else could have been done then? And the evaluative question is, what would be the trajectory of option that was taken versus the option that was not taken, both of which arguably were feasible in 2010. And just to give you an example of what I would have encouraged people to think about in 2010, that in my view was either doable then or arguably a politically advantageous argument to make. For his goals, for Obama's goals, I would have said that lowering the age of eligibility for Medicare from 65 to 55, and at the same time turning the deduction for medical care expenses of 7.5% of adjusted gross income into a refundable tax credit would have turned that into a catastrophic protection plan for all Americans and involved none of the extraordinary upset that's followed in the wake of the 4-part reform that I did. I only say this to open your minds and to stimulate you to think differently about counterfactuals, which are an important part of evaluation. Now, if I speak any further, I'll go beyond the limit that I was given, but I can't remember exactly what it is, so I'll stop right there. Thank you very much. And the rule here is if you've got any comment or question, I'll repeat it to the crowd so as to not run around with putting you in the position of I don't know what, Ted Koppel or something 20 years ago. Yes, ma'am.
If I promise to buy your book, will you tell us your opinion?
I'll do that at the end, but not right now. Okay? Yes. The question was, if she buys the book, will I tell her my opinion of what should have happened? I've sort of hinted at it already, and I said I would do so at the end, not at the beginning, so as to keep some uncertainty. Yes, sir.
When you were speaking about the split governments, what specifically would you
The question here is, could I fill out my claim that American government is counter-majoritarian and that it's designed to stop rather than to do? It's an 18th century constitution and 21st century responsibilities. What I mean by that is something simple. When we have elections, we don't elect a majority to do anything. There's no policy that flows from our elections because 1/3 of the Senate is elected, not 2/3 are not. They know no allegiance to any particular policy. And although the Congress is elected every 2 years, and hence with a president, it's so gerrymandered that whether they succeed or not has modest amount to do with what the president does. And then, as you will see if you look at what the book's about, an enormous amount of American government is decentralized, even from federal programs. So the disability program of the national government is administered at the state. We do an enormous amount of education work at the state level. So we decentralize aerially as well as distribute or disperse at any one level. And that's what I meant. And so as soon as Senator Kennedy died, the politics of this were changed dramatically. And the possibility of a filibuster was real. And they had to get a senator from Philadelphia, from Pennsylvania, to change parties to keep part of it going. Well, if you think about it, just imagine back to 1964, 65. I was in the government. I wrote a book about the politics of Medicare. What a different world that was. The ratio of Democrats to Republicans was 2-1. There was no chance of stopping Medicare. It was so overwhelming that the conservatives added Medicaid and Part B to it. That, if anybody knows that in this group, I'll give them my book. But that's not known very well. So that's that. Yes, ma'am.
So if the House and the Senate were to be taken over by the Republicans and they succeed in repealing Obamacare, what's the proposal going to be? If it comes to fruition that the Republicans take control of the House and the Senate,
Oh, okay. So
and their goal is to repeal Obamacare, what are they proposing to do?
good question. Let me state it to the group as a whole. This is a forecasting question. What, under circumstances where Republicans gain control of the presidency, but certainly gain control of the House and the Senate, according to you, what will happen then? Well, that's a good question, but the important thing would be to break up the Obama program into 4 parts and acknowledge that they're not all tightly bound to one another. And so what you would expect is an attack on the mandate, both of individuals and of firms. You would expect loosening up of the loose requirements already about what you have to do if you have less than 50 workers, and even less in terms of the penalty. I mean, the problem of the Obama conception of universal coverage is that hinges on 52 million Americans getting signed up for insurance. Well, at the rate we're going, it's going to be a snowball's hell before that happens. And there's all sorts of adjustments already made. So my suggestion would be that I don't think there's any turning back on what I would call the adjustments to the rules of the game of health insurance. Not mandates, but rather the pre-existing conditions, all of those, which are really meant to deal with the access to health insurance for people when they really need it. And there's broad bipartisan understanding of that. But the question of coercion of legislation that imposes penalties either on firms or on individuals, it's either subject to bureaucratic unwillingness to do it, that's part of it, or levels of fines so little that they won't make any difference, or it will be the subject of cutting back on the legal side. And we'll see, in terms of Medicaid, we'll see a continuing split between those red states that want the money and those red states that want to be critical, and those blue states that want the money, and those blue states that have even biggest ambitions. So that will be a world that will be completely uncertain. But the idea that they will repeal it all, well, they can't repeal it as long as he's president, so they can starve it. They can starve it bureaucratically, they can starve it temporally, and we've seen a lot of that going on. So under the circumstances of 2014, we're going to have, if you want to have me back, I'll be happy to come back in 2014 to review what we've said now. But if it goes to the Republicans in the Senate and continues in the House, we're going to have incredible stalemate and a fight over every aspect that they can control. And I should tell you as well that the United States is not the only place in the world that has experimented with having competition among insurance companies for the uninsured. That's happened in Switzerland in 1996, and it happened in the Netherlands in 2006. And you should know that the consequences of those policy changes, everybody in the country is insured, but is required to be insured. And there are punishing fines for people who don't pay their amount, and intrusive regulatory interventions in people's lives and going into their bank accounts to create liens. And interestingly enough, in the Netherlands, 700 new tax authorities were hired in order to adjust the subsidies for those being subsidized from month to month. So I haven't said much about it, but what you should keep in mind, let me put it to you slightly differently. Let's imagine that the America before the Obama reform was a patchwork of different Americas. There was socialized medicine in the VA, there was European social insurance in Part A of Medicare, there was European poor law with Medicaid, were means-tested programs. 175 million Americans had the health insurance that their bosses or their union bought for them, and there was a national emergency room law, which said you can't dump people out of that because we don't want to be in a society where that happens. Those are the 5 Americas. So call those the patchwork of American medical care. Each of those 5 with radically different explanations about what our obligations were to one another. No common understanding of why it is we should help our neighbors or not. Okay? Now, think about the Obama reforms, the 4 parts I talked about, as a series of patches on a patchwork. Does that metaphor make sense? Now follow that and think about sewing the patches onto the patchwork to make a quilt. Well, if you've had any experience with quilts, you know there's lots of boundary problems. There's lots of edges. There's lots of ways in which it can go wrong. That will give you a handle on the extraordinary number of complexities that have arisen because they decided in 2010 to pursue a strategy which was a complicated aggregation of programs that was not a simplification, but that made more complex what was already complex. Okay? Yes, sir.
My name is Dr. Edward Powers.
Mr. Powers.
I'm a surgeon. Thank you. And thank you for being here. And I've also been kind of I've had an opportunity to travel quite extensively over the last 30 years to the Soviet Union and Russia and looking at that healthcare system. And of course, your name is very famous in Russia. Okay.
I didn't know that. I don't know why it would be.
So one of the things I observed there is they have a system called a Felcher, okay, which is a German word, and that's between a physician and a nurse. And I was wondering when we would begin to see that a felcher in this country. I think we've seen it in terms of the nurse practitioners who really in many respects are doing the hard work physicians were involved in. That's just a common question. New York State now, they have mandatory tests that you have to take, and for a lot of the professions they have this in law and other things. And so I just finished a big series on infectious disease. And one of the things that's in there is if you go into the hospital and you have open heart surgery, you have a coronary artery bypass graft, and you develop an infection in the sternum or on your chest wall, CMS, the Centers for Medicare and Medicaid, have the option of not paying for that treatment.
Right.
Okay? And they can't charge the patient. Okay? And it always is interesting to me, you're talking about a very costly hospitalization and treatment. Somebody's paying it for it somewhere.
Right.
First question. Second question is an observation. It seems like the hospitals are marketing away from certain specialties. For instance, cancer treatment in heart is very much in, while mental illness, addiction, those things are out, okay? And so they're investing money into certain fields and selecting other fields that they're not willing to support. Do you have an opinion on that?
Well, my opinion is that you're accurate about the last point you made. I don't know what else you're looking for except to say that when we pay for medical care the way we do, which is on diagnostic-related groups for hospitalization and for fee schedules for fee-for-service medicine, and never debate what it is that we're paying for, it's not surprising that highly technical interventions get more rewarded than less technical interventions. I didn't know where you were going with the Russian case. I've not been to Russia, but it may well be that felchers are a useful model, but Soviet medicine is not a useful model, in my view, because most of the allocation of medical care has been determined by payments under the table, not above the table. And I don't think any Americans, whatever our vices is, we don't like the idea of people getting access to medical care that way. But what I do think, but what your question has prompted me to think about, is something I haven't mentioned yet, but I should. It's an extension of the debate I say we haven't had in the United States preceding. Basically, the debate we had before 2010 was American medical care was very expensive. We had a lot of uninsured. There were quality problems. We should do something about that. And that diagnosis, however widely believed, is not a guide to remedies. And the key question that we never had a serious debate in this country was, how do we think about the principles that should guide access to medical care? Do we think, for example, can you hear me if I move away a little bit? Oh, you want to imprison me to you. We haven't agreed on this imprisonment, but I'll submit to your gentle authority up there. This is serious. This is a serious topic. There are at least two radically different justifications for why somebody should get a good or service. One is the market test, which is your ability and willingness to pay to a willing supplier should be the determination of who gets what. That's how we allocate cars, how we allocate houses, that's the way we allocate clothes. In a market economy, that's the dominant. Willingness and ability to pay is the determinant of the allocation of access to goods and services. We may transfer some income as in kind with food stamps to make an adjustment, but we leave it to people to work out with suppliers what it is they're willing to sell and what they're willing to buy with the income that's available. We call that a market good. Radically different is what one could call, it's not the only term you could use, a merit good. That is a good or service only to be supplied because of evidence about the capacity to benefit and the degree of need of the person in charge, the person under whose status is being. You could have someone in great need but not able to benefit. For example, an alcoholic who has kidney failure would be an example of that. You could have people who had an ability to benefit, but not all that much need. Certain forms of cosmetic surgery might well satisfy that. But the judgment of what the seriousness of the need and the ability to benefit in medical care is a central principle of the allocation of medical care according to non-market criteria. That's when Canadians say that there's no deductibles in co-insurance when they get universal health insurance, or when a British NHS person says, this care is free at the point of service. Of course it's not free, but it's free at the point of service. What's going on? Well, what's going on is the knowledge that if you put financial barriers between anxiety and care, between injury and care, between worry and care, you will produce a distribution of access to care that reflects the income distribution and not reflects medical need as judged by medical personnel. Now, I've just said this in 2 minutes. Did you hear this between 2007 and 2014? Not once. It's unbelievable. Unbelievable. It's like having a conversation. Well, leave it aside what it's like having a conversation. The thoughts come to mind, which I can't repeat. Yes, sir.
It seems to me that one can summarize the Affordable Care Act as the increase in insurance to the uninsured plus enhancements to others. And what you said earlier in your talk is that a dollar spent is a dollar either in or denied someone's pocket. And therefore, my thoughts have been that until there is some decrease in the total expenditure for health care, the Affordable Care Act will be viewed somewhat negatively by a substantial.
Well, the question is really, won't the ACA, the Affordable Care Act, be criticized as long as medical care expenses continue to rise more rapidly than, for example, national income or per capita income? That's tricky. And I feel as if I'm giving you the FBI files on the truth about health care costs. The American public has been led to a false judgment in the last year by a lot of people with a lot of economic interest in fooling us about the cost of medical care. Have you read headlines in the New York Times or the Wall Street Journal that medical care inflation is falling? Haven't you read that? It's true. I mean, medical care inflation fell to about 4% last year. In the 1970s, it was 10 and 12%. And they're accurate as far as it goes. But what counts about inflation is what's happening to your income at the same time that inflation takes place. What was inflation generally last year? It was about 2% last year on average. Well, that means the ratio is 2 to 1 of medical care to non-medical care inflation. Anything rising at twice the rate of general inflation is going to command more of our income over time. It must follow as day follows night. So that's one thing to take into account. The other, of course, is the difference between the rate of inflation, the rate of increase in overall expenditures, which is about 4% last year, and the rate of increase in premiums, which was 7%, because that cycle forms another one. So people experiencing premium increases are not experiencing the other phenomenon, and that, I don't know anybody who has pointed that out except one, the president of the Kaiser Foundation, who wrote a piece last week saying, is inflation rising faster than it used to? Well, it depends on whom you talk to. Well, that's not true that it depends on it. It's true that you'll get a different story, but it's not true that it depends on whom you're talking to. It depends on what the truth of the claim is. Now, I don't know what. One more question. You've been a very patient man.
Thank you very much. I'm Tom Shaw, I'm an ophthalmologist. I'm also a military veteran with command and staff experience. And I just appreciate any explanation you may have or anybody else here in this audience about the medical licensing system being dysfunctional and unconstitutional. Because now, of course, the Supreme Court decided, or at least decided that will be imposed a tax to see physicians that states cannot legitimately certify as being appropriately qualified to practice medicine. Let me explain what's happened here. Nearly the past decade, I've been raised this issue by legislatures, and some have not addressed this issue. So Senator Bruno called in the head of state medical board, Walter Ramos, who's also a registered nurse, and he's also an attorney. And he said, quote, all state medical boards have no authority over the National Board of Medical Examiners. And as I mentioned to John Ashcroft in a personal meeting, his comment was, I didn't know. Of course, the system is both dysfunctional and unconstitutional. So the question is here for everybody is, how can states really perform their jobs in providing protection and public safety when they have no authority over a testing agency to give licensing exams? And how can physicians who are applying for license verify that their exams are being graded properly, as afforded other regulated professions such as attorneys?
Well, I hate to end on this note, but this is a very technical and special area of American medical care policymaking. I doubt that the constitutionality question will be settled, and I think state authority to set standards for professionals will find a way to be recovered, but it's not an area where I have any special expertise. So although you came and sat up there patiently, I'm sorry I can't answer that question for you.
I just want to thank you, Dr. Marmer. We learned a lot, and it certainly opens up the dialogue, which can go on forever.
Well, and you're going to have Betsy McCoy here next. And let me just alert you that you won't hear the same story from her that you heard from me. Thank you very much.
Thank you.